Good morning, ladies and gentlemen. In this section, I would like to talk about new advances on the submucosal endoscopy. And this is, as we know, submucosal is a wide, loose space. It can act as a working space. So submucosal endoscopy is a new front. So current applications of the third space, I think first is the removal of the large mucosal lesions, and the second is a myotome for achalasia. So as palm for achalasia is a milestone of the third space. We first perform palm case for achalasia in Shanghai in 2010. With this third space, we can cut the circular muscle and the longitudinal muscle around the EG junction. After the procedure, we can see the tight EG junction can be loose very dramatically. So in the DDW 2012, we first reported the word jet assisted palm with a push and pull technique. So with push and pull technique, we can shorten the procedure time to just 30 minutes. So how about the indications of palm achalasia? So traditional indication of the palm is achalasia type 2. Now in China, we just expanded the indication of the palm for achalasia, even for type 1 and type 3. For failed palm case or failed halar myotome, we can even perform repeated myotomy after the palm or halar myotome. So this patient once had the halar myotome, but the symptoms did not resolve 3 years later. So we just choose the posterior wall of the esophagus and perform the repeated palm for this patient. We can see after the halar myotome, the junction is still very tight, and we can see some diverticulum change around the EG junction. See, this patient suffered from the dysphagia for many years, but from the barium swollen, we can see here, yeah, and this is a diffuse spasm of the esophagus. So from the barium swollen, the image shows just like a sugar-coated horse on the stick. So for about longer than 20 centimeters myotomy, we can cut the whole specific muscle along within the tunnel. So in adults, we can perform palm for many patients, but how about the palm in pediatric patients? In Shanghai, we first performed such procedures in the pediatric patients. For this patient that was 7 years old, and the body weight was only 11.5 kilograms. So the patient was diagnosed as a malnutrition and achalasia with tuberculosis. After the palm procedure for this young patient, the patient recovered very well and got the body weight. So for this young child, so after the palm, he can drink, eat everything. So palm have been done for more than 15 years. How about the safety and the efficiency of this procedure? So from our data, in 1,300 patients, 13 patients had a failure procedure, and 12 were associated with severe submucosal fibrosis. For the submucosal fibrosis in achalasia patient, I think is a rare causes of body palm procedures. It can prolong the operation time and can make the mucosal barrier damage. That means it can increase the major adverse events. So how about the long outcomes of the palm for achalasia? From our data, 1 year, the symptomatic relief in 1 year about 94%. With the time goes on, 5 years out, symptoms relief was about 7%. I think the risk of the clinical failure is prior treatment. Prior treatment, that means the patient once had a balloon dilation, stent dilation, Botox injection, and so on. Prior treatment did not increase the adverse event and reflex, but prior treatment increased clinical failure. Recently, there is a randomized medical control, including the 90%. The POM had a high success rate for patients with the persistent or recurrent symptoms of the halomyotomy. So reflex esophagitis was not significantly different between the POM and the balloon and the pneumatic dilation. So we can perform the POM for achalasia. How about G-POM for gastroparesis? Gastroparesis is a simple syndrome defined as a delayed gastric emptying in the absence of the muscle obstruction in the patients. The symptoms include the early sanity, post-parenteral fullness, nausea, vomiting, and so on. The etiology of the gastroparesis include the endocrine, post-surgical, endoscopy level gastroplasty, and medications, and so on. So the traditional treatment of the gastroparesis include medication, endoscopy, Botox injection, balloon dilation, surgery. So we performed the G-POM for the proximal subtotal gastrostomy. The patient, so from the barium swelling, we can find the pylorus was very strict. We just make a short tunnel in the pylorus or in the atrium. Then after that, within short tunnel, we can cut the muscle around the pylorus. So 1 month later, when we recheck the patient, we can find the contrast can pass through the pylorus very smoothly, and the scalp even can pass the pylorus in the duodenum. So this is the data from our center, single center. So 16 patients with G-POM and the severe refractory characters as medicated by GCSI score more than 20. So 13 patients had a post-surgical gastroparesis, and 3 patients had diabetes. Long-term of the efficiency was about 80%. Here's another paper, meta-analysis, including 11 studies, about 900 patients. 7 are respective and 4 are prospective. Adverse events occurred in 62 out of the 835 patients. So from the ESG, G-POM is considered in the carefully selected patients only because it is an emergency procedure with limited data on effectiveness, safety, and durability. From AGA, they suggest offering a G-POM to adult patients with refractory gastroparesis who first had undergone EGD to confirm no mechanical gastric outlet obstruction, and second had a solid phase gastric impedance GES confirming delayed gastric emptying, preferably with retention more than 20%. Now we have, after we had much experience in adult, we then performed the G-POM in the congenital hypertrophic pyloric stenosis. As we know, CHPS is the most common infantile indication requiring surgical intervention in the past. Traditional surgical approaches can cause relatively large trauma and abdominal carrying. So GastroPOM, now G-POM, is a minimally invasive technique that has been applied to the gastroparesis. So the procedure is similar to the G-POM in the adult, but as we know, such patient is very young, and the mucosa is very tender, and the submucosal layer is very thin. So sometimes it is very difficult to control the scalp in the stomach. So this is the first case of the G-POM we performed 4 years ago in Shanghai. The patient was 40 days old, and the body weight was only 5.3 kilograms. So, and this is another case we've performed such a procedure in CNCT. So the procedure time was only 14 minutes. So I think for such procedure in young adults is also very easy. And last month we just finished another case in Shanghai Children's Hospital. The patient was only 22 days old, and I think this is the youngest patient with a GPOM for the CHGS. So GPOM is feasible and safe and effective for infants with CHPS with satisfactory clinical response over the short-term follow-up. Further multi-center studies should be performed to compare long-term outcomes of this minimally invasive technology with those of open or laparoscopic myotomy. So the submucosal tunneling is not only for the palm, so we can use this tunnel to remove big lesions even from the muscle layer. So just in yesterday's live demo, I use this technique named stir to remove the big lesion from the EG junction, from the fundus. So we can now even remove such submucosal tumors in the rectum. And this lesion located on the posterior wall of the duodenum. So for this location, sometimes it's very, very difficult to control the scope. So we just make a short tunnel in the atrium, then cut the pleural muscle so that the submucosal tumor can be exposed very easily. So within tunnel, the whole lesion was removed. After dissection, we can see that here is a huge defect, muscle defect in the duodenum. So the biggest advantage of the tunnel, I think it can maintain the integrity of the mucosa over the tumor. So how about stir for some extraluminal tumors? So we can use this tumor to even cut the whole thickness of the gastrointestinal wall to remove the extraluminal lesion. That means the scope can go from the intraluminal to the extraluminal. This is a new complication of the submucosal endoscopy. So the lesion located between the stomach and the liver, just totally outside of the stomach. So we just make a shorter tunnel over the tumor. Then when we reach the stomach, so we cut the whole layer of the stomach, and so now here is a tumor outside of the stomach. So with this new technique, such extraluminal lesion can be resected very, very successfully. So this is another lesion. The lesion located outside the esophagus, actually it is the mediastinal tumor. So we can now use this technique to remove the lesions from the outside of the esophagus. I think this is a new field for the endotherapy. So now we can use this technique to treat some wrinkles development. So after the tunnel has been made, we can find this septum is very, very thickened within the tunnel. Such thickened septum can be dissected or cut very, very fast and very, very successfully. So for some unknown esophageal stenosis, repeated biopsies always negative. So within tunnel, we can get some tissue biopsy from the muscle. For this patient was 76 years old, diagnosed as esophageal stenosis, but the etiology is still unknown. So with this tunnel, it was at last diagnosed as adenocarcinoma. The third space now can act as a working space. We can use this space to perform some complicated or challenging cases. How about the future of the endoscopy? How about the future of the third space? I think in the future, robotic endoscopy, even with the guidance and some submucosal lesions, so we can use this to remove not only we can perform some procedures not only within the GI tract, or it also we can perform such procedures outside of the GI tract. Thank you very much for your kind attention.